My name is Baram Jam and I'm a physical therapist in Toronto, Canada, and it is my honor to be here today with you for the next 30 minutes and talking about interventions for persistent pain. I'm also honored to be invited by the Virtual Neurology Summit. So sit back, relax, and I hope you enjoy this short talk that I will be having. So before determining and knowing if what intervention is most appropriate for a patient with persistent pain, the possible source of their pain must first be hypothesized. So what do I mean by the source of the pain? Basically, I have three pain classifications that I'd like to talk about. The first one is nociceptive pain, NP. That's basically pain that comes from any musculoskeletal injuries, so from muscles, bones, tendons, ligaments. And it's the most common condition that we see in outpatient orthopedic setting. Then there's peripheral neurogenic pain. This is pain originating from nerve roots typically, or peripheral nerves that are injured. And for example, when a disc herniation compresses a nerve, that's peripheral neurogenic pain. Then the focus of this course though is on central sensitization pain, which means the pain is from the central nervous system, from the brain and the spinal cord that are accentuating and magnifying the symptoms. And of course there's visceral pain, which is beyond the scope of this course. We're talking about kidney, liver, lung disorders. Let's look at this pain diagram, body diagram. The top left image is of a person that may be presenting with perhaps nociceptive pain. The pain is localized. The middle image may be of a person presenting with peripheral neurogenic pain because the pain goes down the leg, and usually the worst pain is in the calf. And the image on the bottom right may be a picture of a person with central sensitization pain. For example, somebody with fibromyalgia. However, if only life were that simple that we could classify pain simply based on a pain diagram. However, let me ask you a question. Is it possible for the person on the left-hand side to have centrally sensitized pain? The answer is yes. You can have local pain and it be still centrally sensitized. What about the person in the middle, pain down the leg? Yes, they could have centrally sensitized pain. Let's talk about nociceptive pain, because it's associated pain from any anatomical structure that has a nerve supply. It's localized to the area of injury, and the pain is predictable. It has aggravating and relieving factors, and it's influenced by movements and postures. Meaning they say, when I do X, Y, and Z, I feel worse. When I do W, X, Y, I feel better. So those are our perfect patients because they have a great prognosis. And the typical pain pattern may be localized. Then we have peripheral neurogenic pain, PNP. This is associated with pain related to neural tissue inflammation, compression, and/or pathology. Pain is deep, knife sharp, and follows a line pattern. Objective neurological signs of myotomal weakness and paresthesia, such as dermatomal loss, which is not necessary to be present in order to have neurogenic pain. And it's usually not difficult to diagnose peripheral neurogenic pain. The pain is usually worse in the extremities, and they may have a positive slump test and positive straight leg raise test, which have been shown to be valid and reliable tests. But the focus of this short talk is on central sensitization pain. This is associated with chronic pain states, and is due to the sensitization of the central nervous system, leading to decreased threshold to all normal afferent inputs. And the conditions that includes fibromyalgia, phantom limb pain, chronic spinal pain, chronic whiplash-associated disorders. And these are typically challenging to treat in a clinical setting. But how do we identify patients with CSP? Well, one of the things they may report is that it hurts even when I just think about moving. They don't really have to move it, they just have to think about it. Oh, my back starts to hurt, even when I thought about bending forward to pick up the suitcase. The pain seems to move around my body. You know, the ones it's on this side of the shoulder and neck, and then it's on the other side, and then it goes more to the thoracic spine. I've developed similar pain on the other side. They typically won't confess to that unless you ask them. Ask them, do you have any similar symptoms on the other side, on the other leg? They say, yeah, I have. They may not tell you in order not to sound like they're crazy talking about their other side. It's of a milder degree, but it's like mirror pain. My whole leg, arm is numb. Now make sure that you've ruled out cord signs, multiple nerve root injuries, and possible vascular issues. But once that stuff have been ruled out, then it may be centrally sensitized. My pain increases for no particular reason. I get unpredictable zaps, like, I just got a pain down my arm for no reason. I was just sitting there. I didn't do anything. So it's a terrible condition to be in because it's very unpredictable. My pain has a mind of its own. It moves around. When you ask them what makes your pain feel better, the answer is everything. What makes your pain feel worse? What makes you feel better? Nothing. What makes your pain feel worse? Everything. Or I don't know is the answer to those questions. My pain is increased by stress. Even though stress increases every type of pain, however, centrally sensitization pain has increased sensitivity to stress. They will confess to this, that stress makes them feel worse. They have increased pain by small movements, such as slightly bending forward or turning increases their pain or flares them up. They may say, I tried to change my bed sheets and I flared up for a week, which is unreasonable. I mean, you'd understand if that happened if they had a fractured vertebrae, but if there's no such trauma, then it doesn't make sense, except when it's centrally sensitized. They may have inconsistent or non-changing centralization peripheralization phenomenon with repeated movements and sustained postures. This is when I put my patients through the McKenzie method of evaluation, method of mechanical diagnosis. And if repeated movements and postures don't influence their pain, they may have central sensitization. Another identifying feature is that they have several failed past treatments, such as physical therapy treatments have failed, massage therapy has been ineffective, chiropractic treatment has not worked, acupuncture treatments has been ineffective, medications including anti-inflammatories and even opioids may take the edge off the pain, but they haven't worked. Injections have failed to give relief, and even surgeries perhaps have failed. The pain diagram may look like this, spread out throughout the body, or it may be localized, as Mal already mentioned. Why is it so important to identify central sensitization pain? Well, it's essential for you to identify CSP, as management focusing on treating specific anatomical structures is likely futile. In fact, treatments such as pain relieving modalities, pain medications, specific manual therapies such as mobilizations and manipulation, and specific localized exercises such as core exercises may all exacerbate the cerebral cortex's focus on pain and even further contribute to chronicity, which is what we don't want. Management of nociceptive pain includes manual therapies such as mobilizations and manipulation, specific exercises, strengthening the cervical spine, strengthening the arm, rotator cuffs, modalities, TENS, interferential current, ultrasound, laser. They can all be effective for nociceptive pain potentially. Management of peripheral neurogenic pain, PNP, includes manual therapy, usually the McKenzie method of repeated movements to try and centralize symptoms, neuromobilizations, such that explained by David Butler, neuroflossing exercises, specific exercises. They may be effective for peripheral neurogenic pain. However, the management of central sensitization pain is quite different. The focus is on reassurance and pain education and fear reduction. Next, the focus is on general exercises, such as mindfulness movements. Next, the focus is on functional goal setting. And no modalities, no manual therapy, and no specific exercises, which is the focus of the next few minutes of this course. So you now know how to identify the three pain classifications: nociceptive pain, NP, peripheral neurogenic pain, PNP, and central sensitization pain, CSP. You now also know that manual therapy, specific exercise prescription, modalities, and focus on specific pathoanatomical structures are all okay for NP and PNP, but not for central sensitization pain. Based on the best available evidence to date, the best intervention strategies for central sensitization pain may be reassurance, pain education, fear reduction, general exercises, mindfulness movement, functional goal setting. So how can clinicians address reassurance, pain education, and fear? I'm going to quote Gordon Waddell, who is a world-renowned orthopedic surgeon from Scotland. He says, "Fear of pain and what we do about it may be more disabling than pain itself." The fear avoidance model has been researched for the last couple of decades, and this is a summary of it. Fear and catastrophization can lead to avoidance of physical activity, can lead to increased disability, can lead to low mood and even depression, can lead to heightened pain experience. What do we do for fear avoidance? We give them appropriate educational materials, such as Explain Pain, written by David Butler and Lorimer Moseley, which is one of the most researched books out there, and I strongly endorse it. Then I suggest avoiding going on internet and searching and Googling how to treat your pain. Another great book, though, is Why Do I Hurt by Adrienne Lowe, who's a physical therapist from the United States. Then, of course, admitting conflict of interest, there's my book, The Pain, Truth, and Nothing But, which is available to you complimentary already. The management of central sensitization pain includes explaining the limitations of radiology. Did you know that patients who receive an MRI for their low back pain and are made unaware of the results, even after 1 year, have significantly higher self-rated general health? Now, I'm quoting just one study. There's so many other studies out there saying that how when patients receive x-rays and MRIs do actually worse. From these studies, I suggested to make a poster. I call this a VOMIT poster. The VOMIT stands for, it's an acronym for Victim of Medical Imaging Technology. Concerned about your x-ray or MRI findings? Prevent yourself from becoming a victim of medical imaging technology. Basically, the summary of the VOMIT poster is that you get the patient to look at certain parts of their body on the poster. For example, if they have neck pain, show them the information about neck pain. It'll show that the vast majority of people, in fact 98% of the population with no neck pain, has degenerative changes in their neck. So 2% of people are freaks of nature that don't have any degeneration. If they have shoulder issues and they've had an MRI or an ultrasound showing they have rotator cuff tear, show them that maybe 50% of people who have no shoulder pain, and even professional baseball pitchers, have rotator cuff tears, and yet they're still able to throw balls at high speed. If they have lumbar spine disc herniation, which an MRI has shown, reassure them that up to 3/4 of people have disc bulges on their MRI, and in the vast majority of people, it's irrelevant that they have an MRI, that they have disc bulging showing on their MRI. So since then, I've changed the name from VOMIT to Medical Imaging: The Untold Truth, because some people didn't like the words vomit. Not that the word vomit was bad, but the word victim of medical imaging technology may not be a good word to use on patients, and I agree. However, this poster is available complimentary to you on the AppTie website. Feel free to download it, feel free to save it, feel free to print as many copies as you wish. I want it to be public domain. And this poster has been translated in 8 different languages. So feel free to access and print it. Pain education may allow patients to think differently about pain and allow them to fear less about pain, allow them to move better and exercise better and push further into pain. Now, another important concept is that we must avoid using medical jargons when trying to diagnose our patients. We can replace the terms with more non-threatening words. Arthritis, replace that word with knee irritation or muscle strain. When patients say, I have knee arthritis, I'm never going to get better, tell them you just have joint irritation. The word arthro means joint. Itis means inflammation. So technically they have joint inflammation, but it's so much less threatening because we all know the word arthritis can mean pain for the rest of your life. Arthritis can mean there's no solution other than surgery or garlic and honey. Arthritis can mean it's progressively worsening condition, when in fact the best thing they can do for their arthritis in majority of cases is exercise and be active. And you can tell them when you have joint irritation, the best thing you can do is move and start an exercise routine. Disc protrusion, replace it with the word tissue inflammation. Again, how can we be sure that the patient's pain is from a disc protrusion when 3/4 of us have potentially disc protrusion on an MRI if we were to get one? This degenerative disease. Now, replace that with tissue irritation. Because how do we know that the patient's symptoms are from their degenerative disc disease when the vast majority of us have the degenerative disc disease in our cervical spine, in our thoracic spine, and our lumbar spine? And we can be rest assured that the vast majority of people who have degenerative disc disease, they don't have any pain from that condition. Scoliosis, replace it with muscle imbalance. Subluxations, replace that term with joint stiffness, because subluxations implies that they're out of alignment, which induces fear, which is counterproductive to recovery. Clinical instability, replace it with muscle weakness. The word instability implies that they can fall apart any moment. And avoid using the words trapped and pinched nerves, because that can inevitably instill fear. And worst of all, people may go Google pinched nerves. Replace it with irritated and sensitive nerves, which is closer to the truth. The vast majority of people who have pain down their legs, when they get an MRI or a CT scan, will not show that they have a pinched nerve. They actually have a sensitive nerve or an irritated nerve. Systematic reviews have shown that patients who learn to actively cope and not fear pain have had better recovery than those who do not have pain education and continue to passively cope with pain. Hence, this pain education is so vital to the recovery. Systematic reviews based on high-quality randomized controlled trials conclude that pain education is effective for chronic musculoskeletal disorders in reducing pain and improving function. Interestingly, the research studies, majority of them are done by physical therapists. The reason I think that's important is that other healthcare professionals need to be aware of this and apply the concepts of pain education to individuals with persistent pain, because it's so evidence-based. So far, we know that management of central sensitization pain includes reassurance, pain education, and fear reduction. How? How can clinicians address reassurance, pain education, and fear reduction? 1. Recommend appropriate reading materials and online videos. Example, Explain Pain book by the physiotherapist in Australia, Lorimer Mosley and David Butler. Why Do I Hurt by Adrian Lowe, physical therapist in the US. And The Pain Truth and Nothing But. And the book is available to you, and the video is freely available on YouTube also. You just have to simply search for The Pain Truth and Nothing But. Explain the Radiology Truth. Example, the vomit poster, again, which is freely available online. Replace diagnosis using medical jargons with less threatening words. Example, replace disc herniation with tissue sensitization. Replace the words arthritis with joint irritation. So, management of central sensitization pain includes reassurance, pain education, fear reduction, and exercises and mindfulness movements. So, the question is, how can clinicians address the need for general exercises and mindfulness movements? Here's the answer. Prescribe mindfulness movements. How can we prescribe mindfulness movement? By advising them to take up an activity that they enjoy. For example, yoga. If they don't like yoga, perhaps Tai Chi, perhaps Feldenkrais classes, perhaps martial arts, or walking program with a group or individually on their own on a treadmill, but ideally outside. Pole walking is a fantastic exercise program. Aqua fitness, if they're limited on their exercises on land, can be a great exercise program for those with persistent pain. And aggressive rehab exercises, which include strengthening exercises, or the exercise series prescribed by Stuart McGill. In order to do this, they need to go to rehab centers where they focus on an aggressive rehabilitation and strengthening program. The minimum amount of daily exercise is 30 minutes a day, ideally done 5 days a week. However, the ideal amount is 60 minutes a day, done 7 times a week. And the goal for all patients should be to eventually reach that timeline. 60 minutes, 7 days a week. Now, let's do a body awareness exercise. I want you to lift your arm up over your head and touch one thumb with the other index finger, like this. And see if you can do it with your eyes closed or eyes open. Now, if you did it, great. If you didn't, it's okay. The point of this was, the reason you could do it is that you had good body awareness and body image. You knew where your thumb was, you knew where your index finger was, and you knew where your shoulders were, and you lifted them up. May not be that accurate. Let's do another exercise. Go ahead. Close your eyes for 1 minute. Close your eyes. Go ahead. You must do this. Now, with your eyes closed, I want you to visualize your trunk of your body. Just visualize it. Your neck, your thoracic spine, your back. Now visualize your left arm. See the outline of your left arm. See the outline of your hands. See if you can wiggle your fingers in your mind's eye. Don't actually do it, just visualize doing it. Now your right arm. Visualize your right hand and wiggle your right fingers. See if you can see the outline of your right hand. Now visualize your left leg. Visualize your whole leg. Visualize your left foot. Wiggle your toes in your mind's eye. Visualize your right leg. Visualize your right foot. Wiggle your right toes. Go ahead. Open your eyes now. The point of this was to show you that you have an image of your body inside your brain. Proprioceptive input determines our physical self-awareness, our body image, and our perceived body map. So the reason you could see that body map in your mind's eye was because you have proprioceptive input from your body. Body image has been shown to be disrupted in people with pain disorders. Now, Dr. Penfield, a pioneering neurosurgeon and a professor at McGill University, was the first person to map out the cortical homunculus in 1951, which is well known to us today, known as the brain map. Dr. Penfield suggested that the size of cortical representation also reflects kinesthetic proprioception, which means the body as felt in motion. Patients with chronic neck and back pain have been shown to have reduced proprioceptive acuity, meaning their joint position sense, awareness of their neck in space, is reduced. Those with back pain, their awareness of the back in space is reduced. Using functional MRIs and somatosensory cortex mapping, researchers have been able to demonstrate these findings on chronic pain. People with chronic low back pain have been shown to have markedly different cortical representation of their back when compared to healthy controls. Let's talk about neuroplasticity a little bit. Michael Merzenich is a leading neuroscientist in the field of neuroplasticity at the University of California, San Francisco. And he says, neuroplastic changes occur when the brain pays close attention while learning. Memorize those words, paying close attention while learning. What's the clinical relevance of this? The more often we're aware and sense and move in a specific pattern, whether we touch something or we're walking, we're throwing, or we go from sit to stand, the pattern gets merged in the homunculus. Neuroplasticity is positive. If you're a violinist, if you're a pianist, if you're a golfer, if you're a figure skater, or if you're learning to drive. That's how we learn activities. So neuroplasticity is good. However, neuroplasticity is negative if you're limping for a prolonged period of time, after an ankle injury, or if you're immobilized and are guarding your neck for a prolonged period of time due to fear and persistent shoulder pain, neck, or low back pain. There's now growing evidence that those with chronic pain have distorted cortical representation of the sensory motor area, representing their specific painful body area. Now I'm quoting a few of the references here, but there are many more that are beyond the scope of this course. The question is, what can we do about it? What can we do about these cortical changes? How can clinicians address need for general exercise and mindfulness movements? The answer is by prescribing mindfulness movement, yoga, tai chi, Feldenkrais group exercises, any type of martial arts, walking program, pole walking program, either at the gym they can walk or in the park, aqua fitness classes if they're unable to do land exercises, going to a rehab clinic where they will prescribe aggressive rehab exercises. And the minimum amount is 30 minutes a day, 5 times a week. The ideal amount is 30 minutes a day, 7 days a week. Once again, Michael Merzenich says, neuroplastic changes occur when the brain pays close attention while learning. So far we know the management of central sensitization pain includes reassurance, pain education, fear reduction, general exercises, and mindfulness movement. But it also includes functional goal setting. Pain control appears to occur by shifting attention away from pain by towards valued goals. So what are some examples of valued goals? Examples of valued goals is such as baking for 30 minutes, or cooking a meal, or going for a walk with the kids, or washing the dog for 30 minutes, or going back to work as a mechanic for 3 hours. The reason for that is that setting small, achievable, specific functional goals is not optional, it is essential for recovery from a persistent pain state. Without clear, meaningful, and exciting goals, the brain will find it hard to get motivated to do anything, including just getting out of bed. However, when you have a goal that I'm going to cook a meal today, I'm going to play with the kids in the park today, I'm going to wash the dog today, or I'm going to work from 9 to 12 o'clock, so I have to get out of bed. These goals give us a reason to function and get out of bed, and inspires us to do our exercise and the activities that we're hoping to achieve. Too often, healthcare professionals see work as the problem rather than the goal or part of the solution, and usually that's wrong. Overall, work is good for physical and mental health and well-being, and lack of employment leads to physical and mental deterioration. Focusing on fear reduction, pain education, physical activity, exercise, and functional goal setting result in significantly higher return to work rates. And there are numerous studies to support this concept. There is significant evidence to support goal setting around valued life activities as an effective means of lifting mood, meaning depression. So how can clinicians assist patients set goals and, most importantly, comply to the goal set? Well, this is a challenging question to answer. But if I had to give 3 methods, one is to consult an occupational therapist at a multidisciplinary pain clinic. However, ideally, all healthcare providers should be able to set goals for their patients, because that's our goal, to get people back to their function, no matter what your healthcare profession is. Consult a trained PGAP clinician. PGAP stands for Progressive Goal Attainment Program, which is an excellent evidence-based program that has been shown to be effective for people with persistent pain to return to their function. A simpler method is have patients complete a patient-specific functional scale, PSFS. And this is done by simply asking the patient, can you tell me 3 activities that are important to you, that you have difficulty doing now, that you'd like to get back into doing? They may say, I want to be able to go golfing again. I want to be able to go back to my yoga classes. I want to be able to walk for 30 minutes. I want to be able to go back to work as a mechanic or whatever. I want to be able to do my gardening. And the patient-specific functional scale is described elsewhere. However, it's an effective way of getting people motivated to exercise and be active and get back to their function. You now know how to identify 3 pain classifications: nociceptive pain, NP, peripheral neurogenic pain, NP, and central sensitization pain. You now also know that manual therapy, specific exercise program, modalities, and focus on specific pathoanatomical structures are all okay for NP and PNP, but not for central sensitization pain. You now know the importance of pain education using tools such as Explain Pain, Why Do I Hurt, and The Pain Truth, and the videos available complimentary on YouTube. Just search for The Pain Truth and nothing but. You now know the importance of explaining the truth about irrelevant medical imaging findings. And the vomit poster is available on the APTI website. Feel free to download it and print it and put it up in your clinic to educate your patients on this important concept. You now know the importance of daily mindfulness movement program that doesn't focus on a specific painful body part. That includes walking, pole walking, yoga, tai chi, aqua fitness exercises. But the minimum amount required is 30 minutes, 5 days a week. Ideal is 60 minutes, 7 days a week. Without an active exercise program, it's very unlikely that a patient will recover from the persistent pain state. You now know neuroplasticity is a negative force if we're inactive, immobilized, and avoiding most of our daily functional activities. However, neuroplasticity is a positive force when we're learning new movements and doing all the activities of daily living. Hence, we focus so much on mindfulness movements and goal setting. You now know that based on the best available evidence to date, the best intervention strategies for central sensitization pain may be reassurance, pain education, fear reduction, general exercise, mindfulness movements, and functional goal setting. And this slide basically summarizes the topics that I wanted to cover in this short time with us. And I want to thank you and tell you to feel free to contact me if you have any questions or you'd like further information on any of the topics that I covered here. And I'd also like to thank the Virtual Neurology Summit for having me.